So friends, let us move to the next topic, that is blood supply of nasal septum and epistaxis. Okay, let's first start with the blood supply of nasal septum. So this is the photograph of the nasal septum as we have discussed earlier also. And there are 5 arteries which supply the nasal septum. So what are these 5 arteries? Let's look at them. Number 1, we have the anterior ethmoidal artery coming from above, anterior ethmoidal artery. Number 2, we have the posterior ethmoidal artery. Okay, now remember both anterior and posterior ethmoidal artery, these are branches of ophthalmic artery. Okay, and ophthalmic artery is the first intracranial branch of ICA. Remember, this is the first intracranial branch of ICA. So before it goes and forms the circle of Willis, it gives the ophthalmic artery, which comes and gives the anterior ethmoidal and posterior ethmoidal arteries. Okay, now number 3 artery that we have is the sphenopalatine artery. Sphenopalatine artery. Okay, it comes from back. It actually comes into the nasal cavity in the lateral wall. Then it gives a branch, a septal branch. The septal branch rotates around above the posterior cavern. It rotates and then it comes and supplies the nasal septum. Okay, so we have the sphenopalatine artery. Number 4, we have the greater palatine artery, comes from below. Okay, you can see it is coming through the hard palate, the greater palatine artery. So this greater palatine artery and the sphenopalatine artery, both these arteries are branches of internal maxillary artery. Okay, now number 5, we have the superior labial artery. So you can see the septal branch of superior labial artery coming from the upper lip, and this superior labial artery is a branch of facial artery. Okay, now the facial artery and the internal maxillary artery, both these are branches of ECA, external carotid artery. So you can notice one thing, that the nose is supplied by both the internal carotid artery system as well as the external carotid artery system. Okay, so it's supplied by both these arteries. Number 1. Number 2, you can see that this is the place of anastomosis between the ICA and the ECA. Okay, so this is a place of anastomosis. As you can see, we have discussed the 5 arteries: anterior ethmoidal, posterior ethmoidal, sphenopalatine, greater palatine and superior labial. Now out of these 5 arteries, if you notice, the 4 arteries are anastomosing with each other. So you see, I have drawn this circle, and these 4 arteries, they are forming an anastomosis between each other in the anterior inferior part of the nasal septum. Okay, anterior inferior part of nasal septum. This place is known as Little's area, and this plexus formed is known as Kisselbach's plexus. Okay, now number 1 thing, this Kisselbach's plexus, this is an arterial plexus. Okay, so please note down that this plexus is an arterial plexus. It is formed between the arteries, right? Okay, now the question comes in the exam, which artery does not contribute to the Kisselbach's plexus? So which artery does not contribute? So we know that all the 4 arteries are contributing except the posterior ethmoidal artery. So remember, the posterior ethmoidal artery does not contribute to the Kisselbach's plexus. Okay, sometimes they can ask you a question like, which branch of ICA contributes? Actually, the question should be which branch of ophthalmic artery contributes, but the ophthalmic artery is a branch of ICA. So this question can also be asked like this, that which branch or sub-branch of ICA is contributing? So answer is anterior ethmoidal artery. So we know anterior is contributing, posterior does not contribute. Right? Okay, now remember Kisselbach's plexus, this is the most common site for epistaxis. Okay, epistaxis means nasal bleeding. This is the most common site for epistaxis. Okay, what kind of epistaxis? You see, when there is a bleeding from the Kisselbach's plexus, from the anterior Little's area, now this blood will come out anteriorly. So this epistaxis is an anterior epistaxis. Okay, so this epistaxis is an anterior epistaxis. Now, before I go on to the epistaxis topic, let's first discuss the few questions that have been asked from this diagram. Number one, which of the following is not the branch of ECA in Kisselbach's plexus? So we know that it's a very straightforward question, that the anterior ethmoidal artery is a branch of ophthalmic artery, which is a branch of ICA, and this is therefore not a branch of ECA. Sphenopalatine artery is a branch of internal maxillary artery. Greater palatine artery is also a branch of internal maxillary artery. Both are branches of ECA. Septal branch of superior labial artery we know is a branch of facial artery, which again is a branch of ECA. Okay, so our answer is anterior ethmoidal artery. Okay, this question was asked in November 2017 in the AIMS exam. Now the next question, all of our branches of ECA that supply the nasal septum except anterior ethmoidal artery, sphenopalatine artery, facial artery, superior labial artery. Okay, so this question was asked in the AIMS May 2019. Okay, so it's a repeat question once again, so we can see that the answer is anterior ethmoidal artery. Let's go to the next question, branch of ICA in Kisselbach's plexus. So branch of ICA in Kisselbach's plexus, branch of ICA, we know that ICA gives ophthalmic artery, which gives anterior ethmoidal and posterior ethmoidal, and anterior ethmoidal supplies the Kisselbach's plexus. So that is the answer once again. Okay, right? So you see that these questions are frequently asked in the exam, so this diagram is very, very important. All right, now we were talking about epistaxis, so let's start with the anterior epistaxis. So we saw that the anterior epistaxis, most common site is Little's area, Kisselbach's plexus. What is the most common cause? Okay, most common cause for this is nose picking. Yes, nose picking is a type of trauma. Okay, so you can say trauma, or you can be specific also that nose picking is the most common cause for epistaxis, anterior epistaxis, right? Now, we can have anterior epistaxis, we can have posterior epistaxis. So we have talked about the anterior epistaxis. Now we can talk about the posterior epistaxis also. So what do I mean by anterior epistaxis and posterior epistaxis? So in simple language, as I was telling you, anterior epistaxis means the blood is coming out anteriorly from the nose. Posterior epistaxis, the blood, instead of coming out from the nose anteriorly, from the anterior nares, it will go through the posterior vena into the throat, into the pharynx, and may come out back from the mouth. Okay, so that is posterior epistaxis. Now the question about posterior epistaxis, what is the most common site for posterior epistaxis? Okay, so the most common site for posterior epistaxis is this area. So what is this area? This is an area on the lateral wall. Okay, so number one, please notice this is an area on the lateral wall behind the posterior end of inferior turbinate and middle turbinate, and this place is known as Woodruff's plexus. Okay, this place is known as Woodruff's plexus. Now the Woodruff's plexus is a venous plexus. So we just discussed that the Kisselbach's plexus is an arterial plexus, whereas the Woodruff's plexus is a venous plexus. Now that is the first difference. We know Kisselbach's plexus is responsible for anterior epistaxis. The Woodruff's plexus is responsible for posterior epistaxis. Okay. Next, the Woodruff's plexus is placed on the lateral wall. Let's not forget that. That's very important. Whereas Kisselbach's plexus we discussed on the septum, that means the medial wall. Okay, so that is very important. Now, this Woodruff's plexus, this venous plexus is supplied by two arteries. Which are those two arteries? Those two arteries are Sphenopalatine artery and ascending pharyngeal artery. Okay. Now, listen to my statement very carefully. When I said Kisselbeck's plexus is formed by 4 arteries, it is an arterial plexus. Of course, it is formed by 4 arteries. Okay. Now, I said Woodruff's plexus is supplied by, I didn't say formed by, I said supplied by 2 arteries, sphenopalatine artery and ascending pharyngeal artery. You see what happens? The arteries, they bring the blood, they divide into capillaries. Now the capillaries, they combine together, they form the venules, and the venules form the veins. Okay, so we have the arteries dividing into arterioles, dividing into capillaries, combining to form venules, and then veins. Right, now these veins, you see, they combine and they form an plexus known as Woodruff's plexus. So the venules or the veins, they combine to form the Woodruff's plexus. Now this is a venous plexus. The blood flow is in the venous phase, but the blood is brought by the artery, sphenopalatine artery and ascending pharyngeal artery. Why am I stressing on the artery over here? Because if there is a bleeding from the Woodruff's plexus, you will search for the artery. You will not search for the vein. Okay, you see, the venules have formed the plexus and later on it will drain into the veins. So the veins, if there is a bleeding, if you go and ligate the veins, it will not solve the matter. You have to go and ligate the supply, and the supply is from the artery. So artery is important in Woodruff's plexus again. Okay, so the Woodruff's plexus is supplied by sphenopalatine artery and ascending pharyngeal artery. All right. Okay. Now, next question. We know that this place is the Woodruff's plexus. Where is the Woodruff's plexus? It is behind the posterior end of middle turbinate and inferior turbinate. We also know that this is the most common site for posterior epistaxis. That also we have discussed. Okay, right? So we know these things. Now, what is the most common cause for posterior epistaxis? Okay, most common cause for posterior epistaxis is idiopathic. Most common cause is idiopathic. All right. Now, this is a very important question over here. Okay. Why? You see, earlier it was believed that the most common cause for posterior epistaxis is hypertension. This was an earlier belief which is now found to be a wrong statement. Why? You have to understand this thing, that whenever a patient will have posterior epistaxis, whenever this patient has posterior epistaxis, the blood from the nasal cavity will go into the pharynx. From the pharynx, the patient will cough it out. It will come in the mouth, okay, and he will spit it out. Now, a patient has epistaxis. Some blood is coming from the nose, a lot of blood is coming from the mouth, okay, and he comes to the emergency. The patient is anxious. His anxiety levels are sky high. Okay, he's very anxious. He's thinking that he's bleeding from everywhere and he may soon die. Okay, the blood has that effect on the people and they get very, very anxious. So when they are anxious, when the anxiety levels are high, when they are having a panic attack, we see that the blood pressure rises. So most of these patients who come with epistaxis, especially the posterior epistaxis, these patients are having a panic attack, they are highly anxious and their blood pressure is high. So earlier it was thought that the blood pressure, the high blood pressure is causing the epistaxis, posterior epistaxis, because it was a common finding in most of these patients. Then a lot of studies was done on the hypertensive patients, and it was found that hypertensive patients do not have any increase in incidence of posterior epistaxis or epistaxis totally. Okay, so a hypertensive patient do not have any increase in incidence of epistaxis as compared to normotensive people. So the rate of incidence in both of them is same. That means hypertension is not causing the epistaxis. Rather, epistaxis is causing increase in blood pressure. Right? So now remember, posterior epistaxis, the hypertension is not the cause. It is not even a cause. Forget about the most common cause. It is now not considered even a cause for epistaxis. Okay, so the most common cause for posterior epistaxis is now taken to be idiopathic. Okay, however, different studies have shown 3 factors which have been shown to increase the rate of epistaxis. So they themselves may not cause epistaxis, but they increase the rate. So they have a positive, or you can say a causative association with posterior epistaxis. They can be probable cause. Number 1 is season. Okay, so epistaxis is more in winter and autumn season. Number 2 is NSAID use, non-steroidal anti-inflammatory drugs use. Okay, and number 3 is alcohol intake, especially in the last 24 hours. Okay, these 3 are the factors or the causes which have a positive association with posterior epistaxis. They are known to increase the risk for posterior epistaxis. Hypertension, however, is not a cause. It has no causative association with posterior epistaxis. Right? Okay. Now, other than this, sometimes a question is asked about Brown's area. It's a small area on the posterior inferior part of the nasal septum medial wall. Remember, the Little's area was in the anterior inferior part of septum. Brown's area is in the posterior inferior part of septum. Woodruff's plexus was on the lateral wall. Okay, now this Brown's area, why is this important? This is important because, you know, there is a small anastomosis over here of the different veins, and these veins sometimes lead to bleeding. So this Brown area is also prone to epistaxis or bleeding, not as common as the other 2 areas, but this is sometimes asked. So remember the location for the Brown's area, it is in the posterior inferior part of nasal septum. Other than this, we also have a structure known as retrocolumellar vein. Now this lies just behind the columella, and it may also sometime lead to anterior epistaxis, especially in case of adults. Okay, so that is also present in some cases as a cause for epistaxis. Okay, now let's say we have a patient with epistaxis. Now how will we manage a patient with epistaxis? You see, whenever a patient comes to you with epistaxis, the first and the foremost thing that you can do is you can ask the patient to do nose pinching. Okay, you can ask the patient to do nose pinching. In fact, that the patient should start right from the time of epistaxis at home itself. All right, now how will you advise a patient to do nose pinching? For that, we have a method that is known as Trotter's method. So a patient comes to you. What will you do for the patient? You will make the patient sit on a chair and ask the patient to lean forward. So like over here, the patient is sitting on the chair and the patient is asked to lean forward. Sitting on the chair will help patient falling down, collapsing because of hypotension, because of blood loss. Okay, and the leaning forward will prevent any blood from going into the airway. Okay, so if the patient leans forward, any blood which is going from the posterior choana into the pharynx, patient can spit it out from the mouth. So we want to prevent the blood going into the airway. Now, where do you have to pinch? You have to pinch the nose, the cartilaginous part, and you have to ask the patient to keep the mouth open and breathe through mouth. Okay, how much time should the patient pinch the nose? How much time? The patient should pinch the nose for at least 3 to 5 minutes. Why? We know 1 to 3 minutes is the normal bleeding time. You see, the bleeding time for a normal person is generally 1 to 3 minutes. So minimum 3. So we'll ask around 3 to 5 minutes for a patient to keep the nose pinched so that the bleeding from the vessel stops. We know that generally the bleeding is anterior epistaxis. It's a arterial bleeding. So within 3 minutes it should stop. So 3 to 5 minutes is the time that we ask the patient to pinch the nose. Okay. Now, let's say the patient pinches the nose and still there is bleeding. Bleeding has not stopped. So what will you do? You can examine the patient if you are able to see the bleeding point. Okay. Remember, if you are able to see the bleeding point after thoroughly cleaning the nasal cavity. Okay. So you are able to see it on anterior rhinoscopy. You are able to see the bleeding point after you have suction and clean the nasal cavity. That means it is a case of anterior epistaxis. Okay, if you're able to see the bleeding point, it means clearly it is a case of anterior epistaxis. And what you can do is you can do chemical cautery. Okay, you can use a silver nitrate stick. That's very easy to use. You can use a silver nitrate stick, or you can use trichloroacetic acid, TCA, or you can use carbolic acid. Okay, any of these things you can use, you can apply, and you can cause chemical cautery. Now remember, over here I have said you can use silver nitrate, TCA, carbolic acid. All these are acidic compounds. What are they? They are acidic compound. Why am I using acidic compound? Why am I using an acid? Because the acids, they cause a burn that is known as coagulative necrosis. Okay, they cause coagulative necrosis. There is a formation of a coagulum that will stop the bleeding. Okay, now the acid burns are superficial. Why? Because the acid, they stop their own spread. They cause coagulative necrosis. The coagulum does not allow the acid to spread deeper. Whereas, if you use an alkali, what will happen with an alkali? You see, the alkali, they cause liquefactive necrosis. Okay, what do they cause? They cause liquefactive necrosis. So now, because of the liquefactive necrosis, they will go deeper. So remember, alkali burns, they are deeper and therefore more dangerous. Okay, they are deeper and more dangerous, right? Alkali burns are deeper and dangerous, whereas the acid burns are superficial, right? So what will we use in chemical cautery? We will always use acid. We will not use alkali. Okay, right? Let's look over here. So what is being used? You can see that the silver nitrate stick is being used to form a coagulum over here and stop the bleeding. Okay, now over here I would also like to tell you about a foreign body in the nose. Which foreign body? A button battery. Okay, so you can see, you know that these small button batteries, they are used in the watches, they are used in the hearing aids, they're also used in so many toys. Okay, remote control, some small remote controls for the toys, they are used. Now, these button batteries, they are dangerous if a child while playing them puts them in the nose. Why? Because these button batteries, inside them, they have an alkali. Okay, so they have an alkali, and if the child puts in, because of the nasal secretion, the alkali leaks out and it starts causing liquefactive necrosis. So because of that, there will be destruction of the septum, cartilage, there is destruction of the lateral wall, the turbinates. So now, what treatment you have to do for button battery? The best treatment for the button battery is removal of button battery ASAP, as soon as possible. Okay, so as soon as possible, remove the button battery. Do not wait for the specialist. Okay, do not refer the patient to the specialist. The button battery, the best treatment is the first healthcare worker who meets the child and removes the battery immediately. Okay, if the battery is removed before the alkali leaks out, that is the best thing you can do to the child. Once the alkali has leaked out and the necrosis has started, so there is no point in delaying that, because the destruction has already taken place, right? Okay, so the best treatment is remove the battery ASAP. Immediately try to remove it. All right, now let's say you are not able to identify the bleeding point. If you are not able to identify the bleeding point, what will you do? That means it is not a case of anterior epistaxis. Now it is a case of posterior epistaxis, because the epistaxis point is not visible to you on anterior rhinoscopy. So what will you do? You will now do a endoscopy, and under endoscopy you will do a electrocautery. Okay, so endoscopic electrocautery, remember, this is the treatment of choice for posterior epistaxis. Okay, this is the treatment of choice for posterior epistaxis. Okay, but there may be circumstances during the endoscopic electrocautery that the epistaxis point is not visible. Or let's say there are multiple, or there is a diffuse epistaxis. Okay, now in that scenario, or let's say the endoscope is not available, the endoscopist is not there, or let's say the patient has come under trauma, you don't have the time to do the endoscopy. So there may be many reasons where endoscopy is not possible or is not successful. Now in those cases, what will you do? You will go for packing, nasal packing. Okay, so first thing that we do is anterior nasal packing. Now this anterior nasal packing is done by placing in the anterior nasal cavity ribbon gauge. You can see over here, this is the ribbon gauge that is placed in multiple layers to give the pressure. Now remember, whenever you are doing anterior nasal packing, you have to give pressure. The pressure can be given only when you give bilateral nasal packing. If you put only unilateral pack, it will push the septum to the other side. The pressure will not be enough. So most of the times we prefer bilateral nasal packing to give the pressure. Okay, right? Now for doing this anterior nasal packing, we use a forceps. This is known as Tilly's nasal packing forceps. Okay, now look at the forceps and you will find it has these long and slender prongs over here, so as to take the pack inside the nose. Now remember, do not confuse the Tilly's nasal packing forceps with this forceps. This is the Hartmann's oral forceps. Oral means ear. So this forceps is to be used for the ear. Okay, so it is used basically for packing the EAC. So it does not go in depth. So you can see only this part will go in the EAC. So it is used for the ear. Its main use is in the ear for the EAC. It is not supposed to be used in the nose. Okay, so don't confuse the Tilly's forceps. This is the Tilly's forceps, this is Tilly's nasal packing forceps with the Hartmann's oral forceps. The two have different structure. Okay, these prongs are not long prongs. Okay, they are not supposed to go inside the nasal cavity. You will have less space in maneuvering this forceps inside the nasal cavity. Okay, now let's say you have done anterior nasal packing. Okay, right? You've done the anterior packing. The bleeding has still not stopped. That means the bleeding is from the posteriormost part, maybe from the Woodruff's plexus, and anterior pack is not able to give the pressure over there. So it's a case of posterior epistaxis and your anterior packing is not sufficient to stop the bleeding. Therefore, you will do posterior nasal packing. How can you do that? The simplest way to do the posterior packing is with the help of Foley's catheter. Okay, so what do you do in this Foley's catheter? You put this catheter in the nose. So as you can see, you put it in the nose, all right, and when it is visible behind the palate, okay, behind the tongue in the oropharynx, when this Foley's catheter is visible, then you inflate the bulb, all right, and you pull it back. So as you can see over here, the arrow, after inflating the bulb, you pull it back. Now it will engage behind the septum. Now you can further inflate it. Okay, so once you further inflate it, you can after that clamp it. All right, so this will give the pressure from behind. This is a way of doing posterior nasal packing with the help of Foley's catheter. Now the advantage of this is that this is quite simple. Okay, it is simple and quite easy to do, right? And it does not require general anesthesia. You can do it under local anesthesia. So patient is a patient of trauma. He's presented to you in the emergency. He's having a lot of nasal bleeding and anterior packing is not able to stop the bleeding. You can immediately remove the pack, do a posterior packing, and then after that you can again redo the anterior packing. Okay, so the Foley's catheter packing is very simple because you can do it quickly, simply, and under local anesthesia. No general anesthesia is required. Okay, right. Now let's study the classical posterior nasal packing. What do? We now use a gauge. So as you can see over here, we use a roller gauge. So what we have done over here, we have tied the gauge piece with the help of some sutures. Okay, you can take a bandage and you can tie the bandage with the sutures. All right, and now what you will do is you will take two red rubber catheters, not one, two red rubber catheters, and you will put each of them in each nasal cavity. One by one you will pass them into the pharynx, and as you can see over here, from the oropharynx you will pick them up with the artery forceps and pull them out from the mouth. Okay, so there are two red rubber catheters which are inserted from the nose and they have been pulled from the mouth. Okay, and now what you do is you tie this gauge piece to the red rubber catheter. Okay, so one gauge piece, one gauge has two sutures. Each of the suture is tied to each red rubber catheter and you pull them back. So now what you do is you are going to pull the red rubber catheter, each one from each nasal cavity, you pull them back and this will take the gauge into the nasopharynx, right? Okay, but remember there is soft palate. Okay, that will not allow it to go in. So what you have to do, look in that photograph, what you have to do is you have to take your finger and you have to put the finger in the mouth of the patient, take it till the oropharynx, push the pack with the tip of your finger, index finger, into the nasopharynx. Okay, as you can see, an awake patient will never allow you to put your finger in his mouth and do all this maneuvering. I hope you can get that. There is a risk of your finger being bitten off. So this procedure can be done only under general anesthesia. Okay, so remember I told you Foley's packing you can do under local anesthesia. This has to be done only under general anesthesia. Okay, so you push the pack up and you can tie these sutures anteriorly. The two side rubber catheter is removed. You can tie the two sutures and then you can also do the anterior nasal packing as shown over here. Now this is known as Billock's pack. This classical posterior nasal packing, this is also known as nasopharyngeal pack or the Billock's pack. Right? This is known as classical posterior nasal pack or nasopharyngeal pack or Billock's pack. It is generally done in general anesthesia after big nasal surgeries or skull-based surgeries. okay, or you've done surgeries for the tumor such as juvenile nasopharyngeal angiofibroma. So after that, you prefer to do classical posterior nasal packing, okay, with a Bilox pack. Nowadays, we also have Epistaxis catheters. Okay, so what do we have? We have Epistaxis catheters. Now, what are these? These are balloon catheters that you can put in the nose and you can just simply inflate them. So now they are made of specific sizes as per the nasal cavity size, and they have different balloons, anterior balloon, posterior balloon, both anterior and posterior balloon. So you see, look over here. If you want to control only the anterior epistaxis, you can use a balloon. Only one balloon is there, which has, anterior pack. For the anterior packing, it will inflate only in the nasal cavity. Then we have this catheter which has two balloons. One will inflate in the posterior space, the other one will inflate in the anterior space, and you can inflate them separately to provide epistaxis control. Okay, so these types of balloon catheters are specific balloon catheters are also now available to control the bleeding, right? Okay, now, so for how much long will you keep the nasal pack? Now, we generally keep the nasal pack for 48 hours. You can stretch it to 72 hours. That means 2 to 3 days. That is the duration of nasal packing. Okay, let's say you do a nasal packing, you keep it for 2 to 3 days. Now, after 2 to 3 days, you remove the pack and patient still has bleeding. That means your packing has not solved the problem. Despite the nasal packing, there is still bleeding. So what will you do now? Now you will try and go and ligate the bleeding vessel. Okay, now which vessel you must ligate? Which vessel? You see, the most common artery involved in epistaxis is sphenopalatine artery. You remember sphenopalatine artery, it supplies the Kisselbeck's plexus. It is a part of Kisselbeck's plexus. Also, it supplies the Woodruff's plexus. So this artery is involved, whether it is anterior epistaxis or posterior epistaxis, this artery is involved. It has the maximum surface area in the nasal cavity. So this is the most common artery involved in epistaxis. We also call it as artery of epistaxis. So what do we call it? We call it as artery of epistaxis, right? Sphenopalatine artery. So if we have to ligate the bleeding vessel, the first vessel that you will think about ligating is the sphenopalatine artery. Now, how will you ligate the sphenopalatine artery? What we do nowadays is endoscopic sphenopalatine artery ligation. Okay, what we do is endoscopic sphenopalatine artery ligation. So we know that the sphenopalatine artery comes into the nasal cavity from the sphenopalatine foramen. Okay, so it comes into the nasal cavity from the sphenopalatine foramen, and this sphenopalatine foramen lies just near the posterior end of middle turbinate. Okay, so on the lateral wall. So it lies near the posterior end of middle turbinate on the lateral wall. So what we will do is we give an incision on the lateral wall. So as you can see, an incision has been given on the lateral wall. The flap is elevated. So when we suction it out, we can see the artery, and then the artery is cauterized. So you can see that after cauterizing the artery, everything is blanched. The most of the nasal cavity has become white because the bleeding has stopped. Okay, so this is how we do the sphenopalatine artery. This is known as ESPAL. Nowadays, this is done under endoscopic vision. Okay, now let's say there is a tumor over here, and you cannot do the sphenopalatine artery ligation because there is a tumor or there is too much of bleeding. So you don't want to disturb this area, now what can you do? You can go and ligate the internal maxillary artery. Remember, sphenopalatine artery is a branch of internal maxillary artery. Now, where is the internal maxillary artery? You see, the internal maxillary artery is in the infratemporal fossa. So, from the infratemporal fossa, it comes over here into the pterygopalatine fossa. And from the pterygopalatine fossa, it will cross the sphenopalatine foramen and it will come out into the nasal cavity. Okay, let's look over here. We have the inferior turbinate of the nasal cavity. Number 2, we have the maxillary antrum. Okay, number 3, we have the internal maxillary artery. You can see the internal maxillary artery. And number 4, we have over here the sphenopalatine foramen. Okay, so as I was telling you, this is the infratemporal fossa, and this over here we have, you see, these are the pterygoid plates. Okay, so between the maxillary antrum and the pterygoid plates, we have the pterygopalatine fossa. Okay, so now what can we do? We can ligate the internal maxillary artery. The best place is to ligate in the pterygopalatine fossa. Alright, so it's a small fossa. It's easier to identify the internal maxillary artery before it divides and gives the sphenopalatine artery. So what can we do? Number 1, we can use a transantral approach. We can go through the antrum. And number 2, what we can do is we can do a transnasal approach. Okay, now the transnasal approach is nowadays, it has become endoscopic approach. So we do it endoscopically, and the other is transantral approach, which was earlier done. Okay, the transantral approach is, you see in the CT scan, you can once again identify the transantral approach. You are coming through the antrum, across the antrum into the pterygopalatine fossa over here, or you are coming through the nasal cavity across the antrum over here. That is done endoscopically. Okay, now the transantral approach, which was done earlier, is known as Cardwell-Luck operation. Okay, so it's an extension of Cardwell-Luck operation. What do we mean by Cardwell-Luck operation? In the Cardwell-Luck operation, you can see over here, we give a sublabial incision. So incision is given below the upper lip, okay, inside the upper lip, and you lift the flap, you lift the soft tissue, you reach the bone of the maxilla, that is the anterior lateral wall of maxilla. So as you can see over here, this anterior lateral wall of maxilla is being broken so that you can enter into the antrum. So when you enter the antrum from the oral cavity through this approach, sublabial incision, this is known as Cardwell-Luck operation. Okay, and then you can go and break the posterior wall of the antrum and you can directly reach the pterygopalatine fossa, where you can ligate the internal maxillary artery. Right? Okay. Now the Cardwell-Luck operation, most common complication is anesthesia in this region because of damage to the infraorbital nerve. So you can see over here the infraorbital nerve coming out, and this gets damaged. Because of that, there is a anesthesia or a paresthesia in this region. This is very, very common complication. Okay, so we should try and avoid the injury to this infraorbital nerve. Okay, so that's Cardwell-Luck operation. Now another complication, an interesting complication of Cardwell-Luck is oroantral fistula. So if you do not repair this opening nicely, there can happen a fistula between the oral cavity and antrum, that is known as oroantral fistula. Okay, so now this oroantral fistula is a complication of Cardwell-Luck, Now, what treatment will you do for this oroentral fistula? For this oroentral fistula, you have to take out the whole fistulous tract. That means you have to again repeat a Cardwell lock. Okay, you have to repeat Cardwell lock. You have to take out the fistulous tract and close it again. Right? So oroentral fistula, the cause is Cardwell lock operation. The treatment is also Cardwell lock operation. Right? Okay, now let's look at the endoscopic internal maxillary artery ligation. So one we saw was the transantral, this is the transnasal or the endoscopic one. So from the endoscope you can see that we have opened the maxillary antrum. So you see we have opened the maxillary antrum, that is the maxillary antrum visible. This over here is the middle turbinate. So now what we can do is we can cut the mucosa of the maxillary antrum, and with the help of a drill we can cut out the bone, we can drill out the bone of the posterior wall. So as you can see, a drill is being used to drill the posterior wall of the maxilla. So once you do that, now you can see that there is a periosteum layer that is covering the posterior wall of the maxilla. So once you cut it, you can see the fat as well as the internal maxillary artery coming out or lying in the pterygopalatine fossa. Okay, so now what you can do is you can ligate this artery, right? So you can ligate this artery very easily over here in the pterygopalatine fossa. Sometimes there is a tumor in the pterygopalatine fossa and it may not be possible for you to ligate the vessel in the pterygopalatine fossa. In this circumstance, you can go more laterally and you can ligate it in the infratemporal fossa also. Right? Okay. So that was the endoscopic internal maxillary artery ligation. Now, as I was saying that let's say there is a tumor. The tumor is it is occupying the nose, it is occupying the antrum, it is occupying the pterygopalatine fossa. You are not able to reach anywhere. Now, you don't want to touch the nose. Okay. So, is there any way you can stop the bleeding without touching the nose? Can you ligate it somewhere else? Yes, you can ligate it in the neck, away from the nose. Okay, remember internal maxillary artery is a branch of ECA. So you can do a dissection in the nose, you can dissect out the external carotid artery and you can ligate the external carotid artery in the neck. Okay, now remember, you never ligate the ICA. Okay, so this question is asked, which artery is never ligated? So the answer is ICA, internal carotid artery. Okay, so the ICA is never ligated. Why? Because that will lead to stroke, it will lead to hemiplegia or paraplegia. Okay, so it will cause problem in the brain. So you never ligate the ICA. Right? Okay, now let's say you have ligated the ECA. The bleeding has still not stopped. So the bleeding has still not stopped. Now you see only the branches of ICA are left and we have two branches, anterior ethmoidal, posterior ethmoidal. Now remember, the posterior ethmoidal is a very small artery. It does not bleed so much. Okay, especially if we have done 2 days of packing, it will not be that much troublesome. So what will you do? You will go and ligate the anterior ethmoidal artery. So nowadays we do endoscopic anterior ethmoidal artery ligation. Okay, so you can go and do endoscopic anterior ethmoidal artery ligation and that generally stops the bleeding because that is the last culprit left even when the ECA has not stopped the bleeding. Okay, right? So that was about how to control epistaxis. Okay, now let's discuss, let's revise everything what all we have just studied in the form of a flow chart. I know I have taught you serially, but let's have a flow chart. Let's understand what all we have just studied. The management of epistaxis is a step-by-step management. Right? So let's see over here, what is the management strategy for epistaxis? Now a patient of epistaxis come to you, the first thing that you will always do whenever there is a bleeding is resuscitation. Okay, we'll check the blood pressure, whether the patient is undergoing hypotension. We'll check the pulse, whether the patient is undergoing tachycardia, how much blood loss the patient has already had, whether the patient needs fluids, blood, anything. Okay, so first step is always resuscitation. Right, now after that you will first ask the patient to do nose pinching. We have discussed the Trotter's method. Right, okay, now the nose pinching does not stop the bleeding. What will you do now? You will try to identify the bleeding vessel on anterior rhinoscopy. Okay, if the bleeding vessel is visible, what will you do? That means it is a case of anterior epistaxis. You can do a chemical cautery we discussed with silver nitrate or carbolic acid or trichloroacetic acid, or you can even use electrocautery over there. However, if the bleeding point is not visible, that means it is a case of posterior epistaxis. Okay, for posterior epistaxis, the treatment of choice is endoscopic electrocautery. Okay, so what is it? Endoscopic electrocautery. Now, let's say the endoscopic electrocautery fails. So the next step is it fails or it is not possible. So you will do is bilateral anterior nasal packing. Okay, now the bilateral anterior nasal packing is not able to stop the bleeding. It fails. So you will have to do both anterior nasal packing as well as posterior nasal packing. Okay, right. Now, how long do you keep the pack? We keep the pack for 48 hours at least. Okay, you can also keep it for 72 hours in some cases. Now, if after removing the packing, patient is still having bleeding, what will you do? You will go for now vessel ligation. Okay, what vessel ligation you will prefer? The first one is endoscopic sphenopalatine artery ligation. If that is not, possible, or that is not solving your problem, you can go for internal maxillary artery ligation. If that is not solving, you can go for external carotid artery ligation away from the nose. Okay, and or along with that, you can also go for anterior artery ligation if ECA, after ECA also there is bleeding. Right, so this is how you manage a case of epistaxis. Remember, we never ligate the internal carotid artery. Right, okay. Now before we end this topic, let us discuss one disease that is known as hereditary hemorrhagic telangiectasia, HHT. This is also known as Osler-Weber-Rendu disease. Okay, now this is a hereditary disease and we identified with the help of a criteria. The criteria is known as Kurakau criteria. This Kurakau criteria has 4 different parts, and out of those 4 criteria, at least 3 must be present to call it as HHT or Osler-Weber-Rendu disease. So what are the 4 criteria of Kurakau? Number 1 is spontaneous recurrent epistaxis. Okay, spontaneous, that means without any trauma, without any injury, spontaneous. Okay, recurrent, multiple times. Number 2 is telangiectasias. In the lips, in the buccal mucosa, finger, nails, okay, nose. So that has to be there, telangiectasia. Number 3, patient can have arteriovenous malformations. So patient should have the arteriovenous malformations, AVMs. And number 4, patient should have a family history in the first degree relative. It is a autosomal dominant disease. Okay, so this disease is an autosomal dominant disease. So in the first degree relative, there should be family history. So out of these 4, at least 3 must be present to call it a definitive case of HHT, Osler-Weber-Rendu disease. Right? Okay, thank you.